All right, good afternoon, everybody. My name is Jay Bremer, and I will be presenting on tricyclic antidepressant overdoses. Our objective today is identify current therapy using a tricyclic antidepressant overdose. Starting with our patient case, we have a 21-year-old female brought to the ED by Salt Lake City Fire Department after she was found next to an empty bottle of nortriptyline 25 milligrams. She's had one seizure lasting about 1 minute that resolved with lorazepam. On physical exam, she has altered mental status. She's delirious. She's agitated. Her pupils are dilated and poorly reactive to light, and her mucous membranes are dry. On a 12-lead ECG, she has sinus tachycardia with a rate of 130 beats per minute, a QRS of 124, and a QTC of 503. So looking at the history of TCAs, in the 1950s, the first TCA, Impramine, was developed and marketed for depression. However, shortly thereafter, in the 1960s, both cardiovascular and CNS toxicities were recognized as major complications of overdoses. TCAs were still used up into the 1990s, with the introduction of SSRIs significantly decreasing the amount of prescribing for TCAs. However, they're still used commonly today for disease states such as chronic pain, migraines, or even ADHD in children. At therapeutic doses, TCAs are going to inhibit both presynaptic reuptake at both the serotonin and norepinephrine reuptake transporters, causing an increased amount of neurotransmitters in the CNS, therefore helping with patients' depression. They do have relatively narrow therapeutic indexes, with therapeutic dosing usually between the 2 to 4 mg per kg per day, and toxic dosing being in the range of 10 to 20 mg per kg. In our pediatric patients, dosing as low as 5 milligrams per kilo can potentially be life-threatening. Where TCAs are going to get the majority of their side effects are going to be due to their antagonism of other receptors, such as peripheral and central histamine receptors. This is going to cause agitation, delirium, and depressed sensorium. They are all competitive antagonists of the muscarinic acetylcholine receptors, causing reflux sinus tachycardia. They antagonize peripheral alpha 1 adrenergic receptors, causing postural hypotension. And lastly, the binding of the TCA to cardiac sodium channels causes a membrane stabilizing effect. And this acute cardiovascular toxicity is going to primarily be responsible for our morbidity and mortality for our patients. Additionally, patients are going to commonly have seizures, and although the causative mechanism is not known, this is something that we will commonly see. Our first line therapy for patients presenting is going to be activated charcoal, and we're going to want to use this within 1 hour of the ingestion to help absorb the TCA and prevent any further absorption. Additionally, after endotracheal intubation, a doctor can consider oral gastric lavage, and this can even be considered up to 12 hours post ingestion due to the delayed gastric emptying caused by the anticholinergic side effects. For our patients presenting in with seizures, our first line is going to be benzodiazepines, such as midazolam 5 to 10 milligrams intramuscular or lorazepam 4 milligrams IV. If patients' seizures are continuing, we can consider barbiturates such as phenobarb or even doing a continuous infusion of midazolam or propofol. However, the seizures are usually self-limiting and patients are not likely to have status epilepticus. Our mainstay of therapy is going to be sodium bicarb, 1 to 2 milliequivalents per kilo IV boluses every 3 to 5 minutes. You're going to want to treat patients if their QRS is greater than 100. However, if you do talk to some poison centers, they may not say to treat unless the QRS is greater than 110. Sodium bicarb is going to reverse the membrane's depressant effects by increasing the extracellular concentrations of sodium, which therefore overwhelms the effective blockade of the sodium channels, while also decreasing the number of ionized TCAs that are able to interact with sodium channels. Once your QRS is narrowed and your hypotension is improving, it's reasonable to go ahead and start a sodium bicarb drip at that time to help maintain our goal serum pH, as the TCAs may redistribute from the tissue back into the blood. In our patients that are going to have more refractory poisoning and are even on the verge of death, we can consider using a 20% lipid emulsion. And this is going to help absorb the TCA, therefore decreasing the toxic cardiac effects, as TCAs are highly lipophilic. The dosing seen here is based off the American College of Medical Toxicology positional statement released in 2016, and this allows for a prolonged administration of the lipid emulsion as compared to our typical seen local anesthetic overdosing dosing. However, with TCAs having a high volume of distribution, it's actually not recommended to use ECMO for patients, um, nor is it recommended to use hemodialysis. With that, our final takeaways are going to be that the acute cardiovascular toxicities caused by a TCA overdose is going to be responsible for the majority of our morbidity and mortality in our patients. We're going to want to treat our patients if their QRS is greater than 100, and our mainstay of therapy is going to be a sodium bicarb bolus, usually titrating to a serum pH of 7.45 to 7.55. Thank you so much for your time, and I look forward to meeting you all.